Good morning, everybody, and thank you to, I'll call a virtual friend, Mr. Peter Nzioka. I say virtual because we met the first time during the COVID pandemic over the phone, so it's lovely to meet you in person. And also thank you very much to Mr. Leonard Degwa for inviting me to be a part of this conference, which is very important for us in terms of laboratory diagnostics and something that's dear to my heart. So thank you for this opportunity as well to be able to share with you the work we are doing at the Chemical Contrast Research Program. I just want to give a brief introduction about the program itself. So we are a research lab, primarily a research lab, based in Kilifi County. We are a partnership between KEMRI, which is the KEMRI headquarters in Nairobi, the University of Oxford, and Wellcome Trust. So Wellcome Trust are a funder in the UK. They're a foundation or a charity-based foundation, and they fund a lot of the work that we do. So a lot of the work that we're doing is research-based, but of course, we work within an ecosystem. And so we're placed behind the Kilifi County Hospital, but we have presence within the Kilifi County Hospital, and we support with microbiological diagnosis, as well as, I should say, biochemistry, hematology, to support clinical care within the Kilifi County Hospital. So I thought I'd give you that as an introduction before I set off with the title of the talk I've given it today is Medical Laboratory Diagnosis in Global Health. And the reason I say global health is because what we focus on at Chemical Contrast Research Program is achieving better health by investigating, doing research on global health. So this comes under the pillar of the universal health coverage. So I've taken this from the policy. But what I wanted to just highlight is the text I've put in bold. So for us to achieve universal health care coverage, we need to put into place efficient health service delivery systems. So that's the only thing I wanted to highlight, because that's, I think, the crux of what we're discussing here today. How do we improve healthcare delivery? And for me, the important bit is diagnosis. If you can't count it, you can't control it, and you can't manage it. And so diagnosis allows us to effectively identify what is making our population sick and effectively manage those cases so that we can improve healthcare across the board. So for me, universal healthcare coverage starts in the lab. Of course, others may argue differently. So how we view this in our setup is through an integrated surveillance system. So for me, surveillance is being able to count your problem. If you can quantify your problem, you can then figure out how to control it and how to manage it. And I think that was very evident in the COVID pandemic. So we, as I mentioned, are in Kilifi County. I'll see if I have the pointer here. Yeah. And that section of Kilifi County is the area, it's about 800 square kilometers that we cover. And those are households within, we've mapped out those households. We know their GPS coordinates, and we do census 3 times a year in this community. Now, if anyone from this community ends up in a health facility, being Kilifi County Hospital, we're able to track that. So we will know within this community how many people have been sick, how many episodes of malaria, how many episodes of pneumonia they may have had, because they will show up at the Kilifi County Hospital, and we're able to track them using a unique identifier number. At the same time, when that sample, whether it comes from the community or from the health facility from that patient, ends up in our laboratory, we're able to integrate all of those and track that sample in the lab to the patient in the hospital, to their clinical outcome, and back into the community. So in that way, we're able to count how many episodes of a particular infection an individual within that community has had. And so we've had this presence in Kilifi County for about over 30 years now. So if I give you the example of malaria, we can show you data from about 1995 as to how malaria cases have changed over time. And one of the outputs of measuring that is we've seen a decline in malaria cases in Kilifi County Hospital from about 2000 to about 2015, and then a small increase in 2017, 2018. And so when you're able to track at your community to that extent, you can begin to understand what interventions have you put in place that may have caused that reduction in cases. And so that would be the same if for somebody, I do malaria research, that would be the same for somebody who's looking at any bacterial infections or any viral infections. Okay. So how do we do this? I think already we've talked about, for me, the points are around personnel and infrastructure. So for us within our laboratory, we are keen on ensuring we have the right technical expertise and personnel with the right competencies and qualifications to be able to support not only laboratory diagnosis, but research. So we have 4 laboratories. One does immunology and molecular biology, another one on microbiology with a biosafety level 3 laboratory. Which is access restricted, a clinical trials laboratory, which also does diagnosis within Kilifi County Hospital, and an insectary where we grow mosquitoes so that we can do some in vitro analyses on them. And supporting all of those labs is a biobank. So these are an array of -80 freezers that have kept samples we've collected over the last 30 years. And these are also samples that are collected from Kilifi County Hospital. So again, we've been able to track, for instance, antimicrobial resistance, and those samples are stored in the freezer. So you can go back in time and compare what was going on previously with what is currently going on. And those samples would range from anything from stool to serum to urine to saliva to blood, and blood split into its various components so that we can do analyses on various infections. We're very keen on quality assurance and quality control, and we have a laboratory health and safety officer. And so this quality underpins everything within the laboratory. It initially started in our clinical trials lab because we support clinical trials. So if a vaccine were to come into Kenya, we could be a site that can test whether that vaccine would be appropriate for our population. So for instance, in the COVID pandemic, there was a COVID vaccine. We were involved in supporting that trial in Kilifi County in a safe way and collecting data under quality assured process. We do manage our own laboratory supplies, though we sit within the wider institution, but we have to manage our own because we understand the nitty-gritties of laboratory items. This is key for us as well. So we have equipment that are infrastructure. I've shown you some of the pieces of equipment we have here. How are these maintained? We can't keep getting engineers from Dubai or the UK or the US to come and maintain these. So we ensure that we have biomedical engineers on site who, when the instrument is put in the laboratory, they're trained on it. They can do some basic or technical, however far technical they can go to help us keep those equipment up and running and maintain them. And then finally, as I said, we engage with the community. So we do have a project manager and a field team equivalent. We call them field workers, but they're equivalent to community health volunteers. But these are specific to us. And so these cutting edge pieces of equipment allow us to do the research that we do that also informs diagnosis, informs the vaccine design across a large range of pathogens that I will show you. I'm sure some of you are aware of the MALDI-TOF machine, which has really revolutionized how we do microbiological diagnosis, and allowing us to shorten the turnaround time for detecting bacterial pathogens in blood. As I mentioned, our labs are all good clinical laboratory practice accredited, so that's because we do research, so that's our main base for ensuring that everything we do is quality assured. I mentioned we had a number of labs. So this is our clinical trial labs. This is our short turnaround time lab. This one is specifically housed near the high dependency unit to give data immediately back to clinicians who are working in the high dependency unit. And all of those processes that we do are quality assured. I'm not going to go into that detail because the previous presentation did a really good job of that. How do we manage our quality assurance process? We use a software called HuQAS that allows us to keep all the documentation, keep all the revised versions, allows our quality assurance team to engage with all the staff within the laboratory through this system so that all the documentation is kept there, all the EQAs, IQCs are all kept in one place, and SOPs are kept in one place in case anyone needs to refer to them. So though we may have hard copies in the lab, this system allows us to have extensive range of soft copies. And it makes it easier when we're undergoing accreditation every year to then access those documents. For us, workflows are critical as well. So when we're thinking about the lab and designing a lab, we're thinking if you're doing a particular process in the lab, you don't want one piece of equipment at one corner of the building and another at the other corner of the building. One, it makes you inefficient. Two, increases your chances of contamination. So we think about the workflow in terms of what pieces of work are individuals doing for whether it's diagnosis or research, and how are pieces of equipment placed in the laboratory. We also think about the personnel. So we have teams involved in the pre-analytical phase. So this is an example of the workflow we developed in the COVID-19 pandemic. So as I mentioned, the institution has been there, but we needed to come up with a workflow for the COVID pandemic. So we had the pre-analytical team, which included our external partners in the coast. So at that time, we were doing COVID testing for the 6 coastal counties. So we were engaging with teams all the way from Kwale and up all the way to Lamu County, into the analytical phase and then the post-analytical phase. And this workflow then allowed us to not only manage how our processes through the laboratory, but also manage the teams required for each of these processes. And so that we could identify what's the human capital required, what is the infrastructure required, and how do we maintain the resources to keep this workflow going and ensure that once a sample comes in for COVID testing, we can push it out within 24 hours. Because at that time, it was a PCR test. So the process for us took about 24 hours to ensure that we've done the test and counter-checked our results and done the QCs around those before releasing any data. And for me, people, as I mentioned, are critical. So this is just an example of all the processes that were involved. The pre-analytical phase where people are discussing, and the post-analytical phase. Did the sample come in? Where's the case investigation form? Yes, it did come in. Where are your results? Before we release it. And that sort of conversations around counter-checking. And then the analytical phase where we were doing all the extractions and PCRs to get the test result. And this is also pre-analytical, where all the data is going in. As the case investigation forms were coming in, we had all our data clerks and data managers managing those case investigation forms. So as the analytical phase was going in, the data was also going at the same time. So when results come out, we could then push this forward to our National Public Health Lab and the Ministry of Health. And that enabled us essentially to do over 100,000 tests within that 2-year period from 2020 to about the end of 2021, early 2022, supporting the Ministry of Health during the COVID pandemic. And so there were a lot of lessons learned from moving to individuals from a primarily research setting into a diagnostic setting to understand the importance of quality assurance. So we had a steep learning curve where we have researchers who are always asking one specific question, asking those staff members to now understand why quality assurance becomes important. And this was a wonderful learning experience for our staff within the institution to take on quality assurance as something important and to understand laboratory diagnostic processes. So why were we able to do over 100,000 tests? I can tell you for a fact it was no mean feat. It meant training people, retraining people, calibrating, recalibrating your processes to ensure efficiencies are improved. So the first time you're learning what are the steps, once you learn what are the steps, who is required to support that process, and then in terms of laying back results and checking the QCs, what teams do we need in place? Our quality assurance team was very key in that. The documentation was already available through our HuQAS system. So we borrowed a lot of that and took it onto the COVID pandemic process. So we have research, as I mentioned, going on to inform global health research. We look at what we call pathogen biology, and we're keen to understand pathogens, which is microorganisms, from the perspective of the host, the pathogen, and the vector for those diseases that have vectors. And we're looking at we're looking at blood. So we're looking at the host and understanding how does the host protect itself from infection? How does the host respond to infection so that we can inform vaccine design or drug design? We're looking at the pathogen to understand where the pathways that there are gaps and limitations that we can exploit for either diagnostic or drug design or vaccine design, and as well as looking at the vector. So how can we block and intervene and stop transmission of these infections? So we do this across a range of diseases from malaria to arboviruses like chikungunya and dengue. We're looking at malnutrition, HIV. We look at respiratory infections such as respiratory syncytial virus, influenza, and of course COVID. And then we're looking at malaria vectors as well. So just to, again, bring to the fore how we think about these things. So I'm sure you're all aware of the routine diagnosis that we do within hospital settings. I just want, a lot of you were introduced to this in the pandemic, the molecular aspect of things. More expensive, requires more reagents, increases your turnaround time slightly, but I'm sure, again, if you've done any TB diagnosis or HIV viral load, then you're used to your Gene Expert, which is a molecular platform. But there's a lot of utility that I just want to highlight around this molecular aspects. And this became evident in the COVID pandemic. So at the start of the process, my first important point is case investigation forms. Data is critical. If we don't have data, none of what we do over here will make sense. So you take your sample, you have your data, and for this case, because it's molecular, we're looking at the molecular component of whatever sample you have, and then we have some detection methods, which is usually PCR-based, and then we go on to what we call sequencing. So for the pandemic, we used to stop here with the molecular, which was the PCR-based. For genomic surveillance, we came into the sequencing. And genomic surveillance, if you remember, was identifying all those variants from the alpha, beta, gamma, delta, etc., Omicron, where we currently are. And then added to that is you have all these bioinformatic tools that you need to use. So just as an example of why data is important, this is data, COVID-19 case data, and it just shows you trends. So a lot of our population we were testing were male, that's number one. A lot of them were within the age of 30 and 40. So if you wanted to think about interventions, these are the sort of data you would have collected at your health facilities that can inform the government. These are your target populations, males between the ages of 30 to 40. Think about what you can do to reduce transmission. So just highlighting why all the data you collect in your health facilities, in your laboratories, become very important in diagnosis, but also understanding how we control diseases in our setting. This is an example of the sequencing. So I talked about alpha, beta, gamma, delta for COVID. This is what we've shown, that we started with the initial Wuhan strain. In the 2020, we shifted to alpha and beta. When this brown bit was the delta, and a lot of people ended up in hospital, and now we're in the Omicron phase. And then Omicron has different subgroups. And this is just showing how it was linked to the case burden. So if I remember correctly, in 2021, this is the delta COVID peak. And what we've been able to do is then produce policy briefs for the Ministry of Health to tell them, at this point you have Omicron, at this point you have beta, at this point you have delta, now we're into Omicron, now we're into a variant of subgroup of Omicron that's caused the spike in cases, for instance, in Kilifi. So what are you going to do about that, and how do we respond and protect the population? And so we've been able to do over 12,000 genomes, and that's informed this whole graph of data from the time we started the pandemic to last month. And the idea behind this is if you can continue monitoring this, you can continue controlling your infection and understanding, as my first point is, universal health coverage. Who do we need to target? What are our current problems in the country? And that's only one disease. So it means we have to think about this at scale for all the diseases in our country. Another example of molecular diagnosis is using PCR. Sorry, the graphs have disappeared. Using PCR to look at different malaria species. So if you've had malaria, you've been infected by Plasmodium falciparum, but there are other species circulating, Plasmodium malariae, Plasmodium ovale, and basically this graph was supposed to show you, this is microscopy, but the PCR graphs are much higher, and you get higher numbers to detect these species. So PCR is superior, though it's expensive, it's superior, and we'd have to think about how do we use that to support laboratory diagnosis and manage our population. This is another study that was using what we call a TACMAN array card that uses a real-time PCR machine. And this one can do, so if this is 96, actually it's more than 96, you can multiplex and do very, very many pathogens all at once. So when this study was done, it's a multi-pathogen detection. You can take a particular blood sample and look. If I don't necessarily know what's infecting that patient, you can use this multi-pathogen approach to find out what the big hits are. So in this case, it's E. coli and rotavirus A potentially that's causing problems in the sample sets that were screened here. And this is from Kilifi County. 2 stories on AMR, meaning different things. So this one, the first one is anti-malarial resistance. To demonstrate that if you use genomic surveillance or sequencing, you can inform how the government have changed policy over time. So if you were sick with malaria in the late 80s, you'd have taken a chloroquine-based drug. In the late 90s, you'd have taken Fancida, which is a sulfadoxine pyrimethamine drug. And now if you're sick with malaria, you're taking an artemisinin-based drug like Coartem. And this just shows you how the government changed policy and switched drugs. So in the late 90s, we switched from chloroquine to Fancida. Why we did that is because when individuals were coming to the health facility with malaria, they were not responding to chloroquine. Chloroquine was a 7-day treatment. People took 7 days of medicine, but still had fever. So clinically, they were not resolving fever. But if you look genetically at the parasite, there is what we call a variant or mutation that's allowing that parasite to escape treatment and still flourish and make you sick. So we're able to track those. So if you took this line, which we call the resistant type, it was at a very high frequency in the late 90s, matching with when we made that switch. And when you make the switch away from chloroquine, those resistant types drop. And this is all just using genetic data and historical samples that were collected in Kilifi County from about 1995 to date. So I just want to demonstrate the power of the work we do in the laboratory. These are all samples. These are blood samples collected in the lab with good clinical data. So from those case investigations formed that have been stored well to maintain integrity. And you can then do these sort of analysis to support not only diagnosis of drug resistance markers for malaria, but then you can also inform the government as to how you might want to do universal healthcare coverage for malaria. Similarly, we looked at, this is not by genomics, but this is antimicrobial resistance now for Klebsiella pneumonia. These are just from blood cultures and looking at the antimicrobial resistance profile. And each of these bars is a different year, 2010 to about 2014. And if you look at ampicillin, it's all at about 100%. So there's data again over time. Ampicillin does not work for Klebsiella pneumonia. I know the time frame for this is behind. I don't have the latest data, but demonstrating if you look at all those blood cultures you have over time, you can begin to make these assessments of what are our current problems in your health facility or in your laboratory, and then track these. So with this sort of information, you can then inform the government, should we really be using ampicillin for Klebsiella pneumonia treatment? So I'd like to finish then with what are the opportunities. I prefer to see opportunities rather than challenges. One is whatever we do in the laboratory to diagnose infections, it has to be integrated into routine surveillance. So even when those patients come in, they come routinely from various parts of the country, your first question is, can we continue to count them? We had a case, I think it was from Coast General, where they weren't sure what was causing these children to have diarrhea. We'd already built this relationship during the pandemic. The samples were sent to us. They were suspicious of cholera, but when we did the assessment, it was actually rotavirus. And one of the questions then people were asking is, our rotavirus vaccine working for the children? And that's important. So routine surveillance across laboratories is important so that we can inform vaccine strategies, any control measures that our government is taking. Data collection, I can't impress upon how that is so important, and continuous strong data collection. One of the lessons we learned in the COVID pandemic is case investigation forms were coming and some data was missing. If data is missing, we don't know, did you forget? Was there an error? Were you not given that information? But without that data, we can't make sense of any of the laboratory tests we do. And then we cannot do routine surveillance in the most robust way. Infrastructure. Infrastructure is everything. One of the reasons within Henry Wellcome Trust, we were able to support 6 counties was the infrastructure was already in place. It's costly, but once it's in, it's about maintaining those and maintaining the personnel who can do that. And my dream one day is to have not only the lab that I work in, only in Kilifi, but across the country. And through conferences like these, ensure that we raise the standard of laboratory diagnosis so that we have a healthier population, and to impress upon our leaders to ensure that our infrastructure is equal to the competencies working in the lab. And sometimes I feel that when you go to a laboratory, the competency of the personnel is great, but unfortunately their infrastructure doesn't support them to deliver the right diagnosis and care. Human capital, it's all in the room, it's all in our health facilities. They're very capable and able to do the work that we want them to do for laboratory diagnosis. And understanding that knowledge gap. We mustn't stop learning. We continued to learn in the COVID pandemic. We were a research lab. We moved at that point 100% to diagnosis, and there was a lot we were learning. And now that learning has transferred, not only the learning from COVID, we're now using that learning in malaria. We used it for the recent cholera outbreak response to the National Public Health Lab. Now we're supporting other infections with the tools that we've learned in the pandemic. I was having a conversation at tea break with my friend here about, from our chair for the KML-TTB board, about costs, equipment, reagents, and maintenance. I think that's always going to be an issue for us so that we can maintain the high quality of laboratory diagnosis. How do we work together to ensure we can drive those costs down and keep providing a good service? The last 2 points are around genomics, and these are specific for genomics, but it's something that with the Ministry of Health, with our lab technicians board, with the National Public Health Lab, discussions are going on to see how we can also add in molecular diagnosis routinely, whether it's done centrally at the National Public Health Lab to support health facilities, and then roll out any molecular tests we can at primary healthcare facilities. Then that would be an important step to improving the quality of care that we provide. So, and with that, that's my final slide. Thank you all very much for this opportunity to talk to you. Thank you.